I just wanted to thank you all for joining. We'll give everyone a few more minutes and then we will get started. Hi, everyone. Thanks again for joining our first webinar of 2026. My name is Mariam Khan. I lead communications for Gradient Health Systems, and I just wanted to do a quick introduction before turning it over to our moderator, Dr. Papicho. Just a few instructions this afternoon. If you have any questions during the webinar, there is a Q&A feature that you can use in Zoom to ask us. This webinar is being recorded and you'll receive a copy of the recording after the webinar. If you don't receive it for some reason, it's on our YouTube page. If you just search Gradient Health Systems on YouTube, or you can go to our website, gradienthealth.org, and go to our training page there. And as always, if you have any feedback or any questions that we don't get to answer, please email customers@gradienthealth.org. Lastly, there will be a few polls during this webinar. They'll pop up on your screen and you can select an answer. They're just a way to keep things interactive, and so we'd love you to participate if you can. I'll turn it over now to our moderator, Dr. Papicho.
Good afternoon and welcome to today's webinar talking about anesthesia for obese patients. We welcome you all. We want it to be an interactive session. There will be a provision of questions that you can ask either in the chat or in the question and answer. And then we have panelists who will be attending to you. To discuss today's presentation, we have two great anesthesiologists of the continent. We have first Dr. Amida Chande. She's anesthesiologist at Ocean Road Cancer Institute in Tanzania, Dar es Salaam. We also have a great presenter who's going to take part in this webinar. That is Dr. Abdullahi Mustafa Mohammed, who is Associate Professor of Anesthesia at Bayero University, Kano in Nigeria. He works at Aminu Kano Teaching Hospital. This is where he practices anesthesia. These are the great two presenters who are going to be with us today. And among the panelists, we have two great panelists. First, we have Dr. Sweetbert. Dr. Sweetbert is a senior anesthesiologist in Tanzania. And the second panelist is Dr. Ndaba, who's also a senior anesthesiologist in Zambia, Lusaka. The question is, we would like to know, why are we discussing anesthesia for obese patients? For those who have been theater before, for those who are practicing anesthesia, we all know that dealing with obese patient, there are a number of challenges. Challenges related to patient himself and challenges as the practitioner who's giving anesthesis. Who's giving anesthesia, the anesthesiologist or the anesthetist on duty. Patient challenges that we are going to tackle today in this discussion is how to handle the airway. You know, the airway is a key feature in a patient undergoing anesthesia. This patient is at risk of having a difficult airway. What are the techniques and what is the recommended steps to take when handling such patient? Another thing to look at that we'll discuss is how to handle the dosing of the drugs that the patient needs. Positioning of the patient during induction, during extubation, what are the recommended? What time should we extubate such patients to prevent them from going into severe hypoxia or difficult airway in post-extubation? So I will not be so long on the floor. I'm going to invite our first presenter, who is Dr. Amida Chande. Dr. Amida Chande, the floor is yours, and please, you can take it over.
Thank you. As I've been introduced before, my name is Hamida Chanda, and I'll be taking you through the first part of the presentation on next slide, please. On looking at the epidemiology as we all know, obesity is defined or is known as the BMI of more than 30 kgs per meter squared, and it has three classes. The first class is where the BMI is 30 to 34.9. The second class is when the BMI is 35 to 39.9. And the third class, which is also called morbid obesity, is when the BMI is more than 40 kgs per meter squared. And there is a super obese. This is another class where the BMI is more than 50 or 60 kgs per meter squared. And by 2022, WHO accounted for more than 1 billion obese patient adults globally. And in our surgical patients, in many of the centers, 40 to 50% of them were obese. So we can see it's almost half of the patients who are being operated in the theater, they are obese. Next slide, please. Let us see on poll number 1. We're going to go through some questions and we can have some answers or contributions in them. And the poll goes like 38 years old female with a BMI of 40 planned for sleeve gastrectomy, presented at an anesthesia clinic for review. The following should be considered when planning for anesthesia. First choice is increased perioperative mortality. Second is risk of difficult airway. Third is altered pharmacokinetics. Fourth is comorbidities like ulcer, type 2 diabetes, and hypertension. And the last option is all above are correct. Please, any volunteer to answer the question or the poll? Anyone?
And if you'd like to speak, you can raise your hand on the Zoom function, and I can unmute you.
Anyone to answer, please, to contribute?
May I answer?
Yes, you can go on.
I would go with the last option. All the above are correct. It should be considered.
Okay, thank you for the answer. Anyone else who has a different answer, maybe? Please feel free to contribute. Anyone? There is no right or wrong answer here. Anyone else?
May I give you an answer?
Yes, please go on.
The answer is risk of aspiration.
Okay, thank you. So we have two answers already for this poll. We can move to the next slide. We'll see for the answers later. So this is why obese matters to anesthesia providers. First, it increases a perioperative mortality 2 to 4 times more than in non-obese patients. And there is also a risk of increased difficult airway, a risk of aspiration, atelectasis, and hypoxia. And there was also altered pharmacokinetics and dynamics with our anesthetic drugs. Some, if they are not given correctly, there will be an overdose or an underdose. It depends on how much you give and whether the drug is lipophilic or not. And there is comorbidities associated with obesity, such as obstructive sleep apnea, obesity hypoventilation syndrome, type 2 diabetes, hypertension, coronary artery disease, non-alcoholic fatty liver disease, and even venous thromboembolism. So I guess this slide answers our first poll. I think the answer is all of the above, where it includes all of these answers. Thank you. Next slide. Going to pathophysiology of obesity, I'll talk about this more on the next slides, where there is respiratory and cardiovascular and other inflammatory changes in obese patients. But then to pick on operative risks of obesity, the anesthetic challenges. First, there is difficulty airway management, especially because of difficult mask ventilation, and also because of the short neck. Then the difficulty in there is difficulty in intubation as well, and the altered pharmacokinetics in the drugs. Also, there are cardiopulmonary complications such as increased cardiac workload and risk of arrhythmias and MI, and complications in wound healing where there is impaired perfusion, as the adipose tissues are centered in the blood vessels, and also there is impaired perfusion, so wound healing is compromised, and also risk of infections and wound dehiscence, and risk of DVT and pulmonary embolism and hypercoagulable states as well. And there is longer operative time due to the body habitus of obese patients, and there is increased postoperative morbidity and mortality as well. Next slide. So going to pathophysiology in the respiratory system, as the weight of the adipose tissues around the rib cage and the abdomen increases, it causes the shifts in the balance between the chest wall pressure and the lung recoil. All these cause the reduce in functional residual capacity. When the functional residual capacity falls more than the usual, then the expiratory residual volume also decreases, which causes increased work of breathing and rapid desaturation in these patients. And because of the adipose tissues in the body, in the respiratory system, there is increased oxygen consumption and carbon dioxide production is also increased. And as the functional residual capacity decreases, the residual volume also decreases, especially if the patient is in supine position, which causes hypoxemia and atelectasis in the dependent lung zones. And in the respiratory system, there is this obesity hypoventilation syndrome, which is a metabolic, is a breathing disorder, or in another name, it's called Pickwickian syndrome, where in obese patients, they have shortness of breath with minimal exertion, causing low oxygen and high carbon dioxide levels in the blood. The patients may present with symptoms such as extreme daytime sleepiness, morning headaches, fatigue, and in 90% of obese patients who have obstructive sleep apnea, they also have obesity hypoventilation syndrome. So in obesity hypoventilation syndrome, the excess weight on the chest and the abdomen causes decreased lung compliance, and increased work of breathing causes hypoxia, increased PaCO2, and all this causes the hypoventilation in these patients. Also, 70 to 80% of obese patients, they have obstructive sleep apnea, and they often go undiagnosed. Next slide. In the pathophysiology of obesity in cardiovascular system, in obese patients, there is increased blood volume to meet the higher metabolic demands of the adipose tissue. So as the blood volume increases, the stroke volume increases as well. And as we know, cardiac output is a product of heart rate and stroke volume. So as the stroke volume increases, the cardiac output increases as well. And there is also an issue of systemic and pulmonary hypertension, where when the sympathetic nervous system is activated in obese patients, there is increased heart rate, which causes increased blood pressure and increased blood volume. The blood pressure is also raised due to insulin retention, where there is increased higher insulin levels in obese patients, causing fluid retention and increased blood pressure as well. And in obesity, because of all these metabolic changes in the body and the heart, they cause left ventricular hypertrophy, which in turn causes diastolic dysfunction, and it can cause heart failure with preserved ejection fraction, where 60 to 80% of obese patients, they develop heart failure with preserved ejection fraction. And as there is more strain on the heart, especially on the right side of the heart, in obesity hyperventilation syndrome, cor pulmonale can also occur in these patients. Next slide. So coming to pharmacokinetics in obese patients, there is increase in volume of distribution of in lipophilic drugs. So anesthetic drugs which are lipophilic, such as propofol or fentanyl, they accumulate in adipose tissues, and if they're given in high doses, they can cause delayed release and prolonged effects in obesity patients. So to be calculated well, they need to be calculated using the lean body weight. And the lean body weight, according to John Mahassan way, It is calculated based on weight, height, and sex, and it should not exceed 100 kgs in men or 70 kgs in women. And it can be calculated for men, where it is calculated as the formula goes with 6,680 plus 216 of the BMI in kgs per meter squared. And in women, it is calculated with a formula which goes as 8,780 plus 244 of the BMI in kgs per meter squared. But for most of our induction agents, they are calculated based on lean body weight and ideal body weight. The muscle relaxants, like the non-depolarizing muscle relaxants, such as vicuronium or rocuronium, they are best calculated in dosage based on the ideal body weight. And other agents, such as ketamine or etomidate, they do not have much effects on the adipose tissues, so they can be calculated anyhow. But for succinylcholine, it is calculated based on the total body weight, so there's no reason to calculate the lean body weight for it. Next slide. So going to preoperative assessment, we go through the history, the examination of the patient. First, in the history, we can ask the patient if they have a high risk of obstructive sleep apnea using the Stockbank score. The Stockbank score goes with the S. You ask the patient if they snore very loudly, or if they have come with a relative, you can ask them, or if they are tired in the day, if they have observed apnea, especially if the relative or the next of kin comes with them, if they have high blood pressure, which goes for the P, if they have a BMI of more than 35, age more than 50, neck circumference more than 49, 43, and if the gender is male. And if the Stockbank score scores more than or equal to 5, then they are at a high risk of obstructive sleep apnea. You can also ask if they have a history of obesity, hypoventilation syndrome, or pulmonary hypertension. Most of them know about it. When you examine them, they have a neck circumference of more than 43 centimeters in women and more than 45 centimeters in men. In Mallampati score, if they score 3 to 4, class 3 or 4 of the Mallampati, if the thyromental distance is more than less than 6, sorry, or if mouth opening is less than 4, then you know this patient is at high risk of difficult intubation and all. And if the functional capacity, if you ask the patient if they cannot lie flat, if they can lie flat and they say they cannot lie flat, then you can assess if they have reduced functional capacity as well. Next slide. Going to investigations, together with the basic or baseline investigations we do for all patients, such as full blood picture, blood grouping. You can do your RFTs, you can do electrolytes, but we can add ECG for obese patients to rule out right ventricular strain or ischemia. You can do an echocardiogram if you suspect pulmonary hypertension or heart failure. You can also do an ABG if OHS is suspected, when they have a daytime SpO2 of less than 94% or a PCO2 of more than 45 millimeters of mercury. And your pulmonary function tests and sleep studies, they're ideal, but they're not feasible in most of our patients in most of our centers, but they can be done. And if you can use your glycated hemoglobin, where if it is more than 6.5, then this patient can be considered diabetic or pre-diabetic, and your LFTs if you are raised, and you can also do a coagulation profile with PT, PTT, and NR to see if they are raised, and be prepared for the patient or optimization before the surgery. Next slide. So your risk stratification tools for obese patients. These tools, they are used to know if the patient is at high risk or low risk of surgery or the procedure they're going to be done. So starting with the first tool, you can do the OSA screening, where you can use the stop bang score, which we already see. You can use the cardiac revised cardiac risk index and obesity, where this is used to estimate the risk of major perioperative cardiac complications such as MI, pulmonary edema, ventricular fibrillation, cardiac arrest, or a heart block. And in the risk cardiac index, it consists of 6 points. There is high risk if there is high risk surgery. 2, if there is history of ischemic heart disease, such as a prior MI or angina. If the patient has history of congestive heart failure, history of cerebrovascular disease, such as stroke or TIA. If they have preoperative insulin-treated diabetes, like if they're using insulin, and preoperative creatinine of more than 177 millimoles per liter. And in this point, if they score 0 or 1, there is a low risk. If they score 2, there is moderate risk, and if they score 3 or more, they are at a high risk. Another stratification tool is the El-Ganzouri score. El-Ganzouri score is in the airway. It is used to predict the likelihood of difficulty tracheo intubation. And by using this score, you can decide between awake intubation or your standard direct laryngoscopy or video laryngoscopy as well. And in El-Ganzouri score, there are 7 points. 1 is mouth opening, the second is thyromental distance, the third is modified Malam particles, the fourth is neck movement, the fifth is ability to prognathe or underbite, the sixth is weight, and if the seventh, if there is history of difficult intubation prior. So if they score 0 to 2 points, they are at low risk. If they score 3, there is moderate risk. And if they score more than or equal to 4, there is generally considered a high risk of difficult intubation. So you need to be careful when planning and prepare well for difficulty intubation. And another certification tool is the postoperative respiratory failure prediction models. And these models, there are like 4 or 5 of them. They consist of the patient factors and procedure factors. Patient factors include old age, low preoperative SpO2 or PaO2, low albumin, anemia, and previous respiratory infections. And the procedure factors include long duration of anesthesia, emergency procedures, and specific types of surgery, whether thoracic or abdominal, then it is known. And among these models, most of the scholars prefer the Nizamuddin model, which demonstrates a strong validation and offer a superior accuracy of predicting prolonged ventilation of more than 48 hours, or if the patient can be reintubated. So when you go through all these risk stratification tools, they put the patient, they help you to know if the patient is at risk or how much the patient is at risk of intubation and the procedure and the drugs and everything that is done to them for the procedure. Next slide. We have poll number 2. So 38 years old female with a BMI of 40, planned for sleeve gastrectomy, presented at Anaesthesia clinic for review. What are important strategies to prevent difficult airway and rapid desaturation? Choice number 1, ramp position. Choice number 2, pre-oxygenation. Choice number 3, apneic oxygenation. Choice number 4, video laryngoscopy, first line. And choice number 5, all above are correct. May I have an answer when you want to contribute on the second poll? If you want to answer, please raise your hand and answer the question. Any
All of them.
volunteers?
Can I answer?
Yes, you can answer.
I think all the above are correct.
Above are correct. Okay. Another one to answer?
I think the same. All are above are correct.
All the above. Correct. Okay. Thank you. Anyone else to answer? Oh, we have the answers here. Most of us answered all of the above are correct. That's great. 9% answered ramp position, pre-oxygenation 8%, below laryngoscopy as first line 1%. Okay, thank you. You can go to the next slide. So, as we know, in obese patients, airway is a complication in most of them, and the challenges include difficult mask ventilation in 5 to 15% of them, and there's a risk of difficult intubation because of the short neck, or the neck circumference is wide. So you can see 10 to 20% of obese patients incur the difficult intubation compared to 2 to 5% of the non-obese. And there is rapid desaturation in less than 90 seconds in extreme obese patients, those who have BMI of more than 40 or 50. So those are your airway challenges. And the strategies to counteract the challenges are first, the ramp position, which someone answered in the poll, where the head elevated laryngoscopy position is done. And in most of the patients, or in most of the anesthetists, if they do the ramp position in obese patient, it has helped to do the intubation well. Then pre-oxygenation can be done using the CPAP, 10 centimeters of water, plus the PEEP valve or the non-invasive. And you can even use apneic oxygenation, where you do continuous uptake of oxygen from the alveoli into the blood, even when apnea occurs, so it prolongs the time. You can use the high flow nasal cannula and at the 30 to 7 liters per minute of oxygen. So this has helped to the patient not to go to apnea or to get hypoxia and desaturate. And video laryngoscopy is a first line for obese patients. So if you have obese patients, if you have an obese patient, better have a video laryngoscopy prepared, so you don't have to use the normal laryngoscopy and get all these troubles again. So if you have a video laryngoscopy, it's way better for these patients. Next slide. So here we see the ramping and positioning of the patient. For the picture on the left, the leg movement and access is hindered by the fat, especially on the chest and the neck. So when you do the ramp position where you elevate shoulders and occiput, so you improve the access of the airway, where the ear to sternum notch alignment, so your ear and the sternum, they are aligned. This helps to heal the airway closely, and you can use towels or the commercial ramps. They are also available to keep the patient in this position. And in laparoscopy, most studies have shown that reverse Trundle back position is better because it improves the functional residual capacity, and also the reserve volume expiratory reserve volume is also improved if the patients are put in reverse Trundle back position in laparoscopic surgeries. Next slide. So yeah, thank you. That was all for the first part of the presentation.
Thank you very much, Dr. Amita Chande. We appreciate that wonderful presentation. We call upon now Dr. Mustafa, who's going to take us to the second part of the presentation. Dr.
Hello,
Mustafa,
thank you very much. Hello, thank you very much, Papa. My name is Mustafa Abdullahi. I'm an anesthesiologist. I'm from Nigeria. Thank you very much. Next slide. I want to remind us about the maintenance of anesthesia, especially in the obese patients, where we want them to recover fast. So we should use an inhalational agent that can be easily breathed out from the lungs, such as desflurane or sevoflurane. They are preferred because they have the faster recovery. Other things that we can use is when we are using TIVA. While using TIVA, you can use propofol and remifentanil because of their short duration of action, and it is a common agent that is used in bariatric patients. These patients, because they have higher MAC value when you are using an inhalational agent, so we need to have a bispectral index so as to know their level of anesthesia, so that they don't have awareness under anesthesia. Thank you very much. Next slide. So this is pool 3. A 38-year-old female with a BMI of 40 planned for sleep gastrectomy presented at anesthesia clinic for review. What will do to prevent atelectasis during mechanical ventilation? Please, can we have somebody to try? Hello? Do we want to try?
If you want to speak again, just raise your hand and I can unmute you.
Okay. If there is nobody who wants to try, okay, let's see the answer in the next slide, whether it is all of the above or we are going to remove anyone. But let's see. Thank you very much.
I think we have one person who might.
Okay. Thank you very much.
Hello.
Hello.
Can you
Yes,
hear
please
me?
go ahead.
Because,
Yes, go ahead.
okay, so I think it's all of the above.
Okay, thank you very much. Any other view? Okay, next slide, since there is not any other view. We see the next slide, please. Okay. So this is the answer pattern, protective ventilation, choice of PEEP, recruitment maneuver, low driving pressure, and then all of the above are correct. So, okay, can we close? Okay, so the ventilation strategy for this obese patient is we need to protect the lungs. So this protective ventilation is we are going to use a lower tidal volume of 6 to 8 mils per kg, and we are going to use the ideal body weight of the patient, not the absolute weight that the patient has. And then we need to also give a recruitment maneuver, and so as to prevent atelectasis. That means we need to have a PEEP, increase the PEEP to between 8 to 15 centimeters of water. The recruitment maneuver that we need to do is to have a sustained pressure in the airway of about 30 to 40 centimeters of water, and then we leave this sustained pressure for up to 30 to 40 seconds, and then we immediately follow it with the addition of the PEEP, so as to sustain the alveoli that are open. We need to keep the driving pressure at low, so that the patient can, at low pressure, start having some ventilation. Next slide, please. So how do we monitor this patient? Basically, the monitoring in this obese patient, we follow the standard monitoring of anesthesia, unless otherwise where we can have a difficulty in getting the blood pressure cuff, then we can use an invasive monitoring. And then this standard monitoring that we usually use, including the capnograph, monitoring the temperature, the ECG, respiratory rate, non-invasive blood pressure, pulse rate, oxygen saturation, and when available, the plasma level, if available. And then we monitor the depth of anesthesia using the bispectral index and entropy, so as to know at which level the patient is. We need to monitor this the level of blockade. So neuromuscular monitoring is mandatory in this group of patients, so as not to give them overdose, and then not to give them they don't have to book for us while doing the surgery. And then given the fluid, we don't rely only on the non-invasive blood pressure that we have or the invasive blood pressure we have. Nowadays, they use the fluid, goal-directed fluid therapy, where they have the variation in either the pulse pressure or stroke volume. These variations are very significant when you have between 10 or below. So that means there is no positive increase. But when between 10 and 13, that is a good value. And the using of esophageal Doppler is also now being used, and you can get the stroke volume using those things. Thank you very much. Please, can you? And in this goal-directed therapy, you use your IV fluid. You can use some inotropes. You can use some inotropes at that time, so that you keep the mean arterial blood pressure at about 65 millimeters of mercury. And then you now monitor the blood pressure and the pulse pressure variation and the stroke volume variation. Thank you. Next slide, please. When we position the patient, because of their weight, the obese patient, they have the weight is increased. So if we don't put their limbs in a neutral position, they are bound to have injury, more especially on the ulnar and then the brachial plexus. So the hand's supposed to be in neutral position. Due to prolonged surgery in a stiff position, they can have some rhabdomyolysis, which can now give them some renal impairment. So what we need to do is to be giving them our fluid so as to keep the renal flow, and then minimize our duration of surgery, and maybe changing from the stiff position time after time. And then also we can have a compartment syndrome, especially if they are using this laparoscopic surgery, when they give higher pneumatic pressure, when they are inflated. And they can also have that due to prolonged pressure if you use the leggings and tie the legs for a long time. And then we can have a pressure also for the prolonged period of time. So these are the things that we use that can happen. Thank you very much. Can we have next slide? Regional anesthesia. So what is it about the regional anesthesia? If you give regional anesthesia to obese patients, there are some advantages that can happen. We all know that there is difficulty in intubating obese patients, so you are avoiding airway challenges if you give regional anesthesia. And then due to the absolute blockade of impulses, it will give you excellent analgesia. So that will make you to have a lower use of opioids. If you can have some challenges if you are using regional anesthesia, because you may have some difficulty in locating the landmark that you are going to use for that regional anesthesia. And then it can give you a prolonged time, because you take time to get the landmark, and then it will give you longer time to instill, to locate and put your local anesthetic where you want to do your local anesthesia. Due to that, you can have a high failure rate. So in order to mitigate this, you can use an ultrasound guided regional anesthesia using the peripheral nerve blocks, or if you are going to use central nerve block. So TAP block can be used, rectus sheet, erectospinal block, it's excellent in giving you analgesia in such patients. Very useful in the bariatric patients. These opiates, if you use them, they can also depress your respiration. So avoiding them will also help you in avoiding some other complications. Thank you very much. Next slide. How do we extubate these patients? For us to extubate this patient, we have to be sure that they are fully reversed. So we have to use our 10/4 ratio of greater than 0.9. These patients are supposed to be extubated awake so that they can control their airway. And then the extubation should be in a sitting position or semi-upright position, so as to reduce the pressure on the diaphragm, which will reduce the functional residual capacity. Before extubating, we need to have a re-intubation set ready, such as the gum elastic bougie as the extent catheter. Video laryngoscope should be around and be ready. In some patients that have obstructive sleep apnea or obesity hypoventilation syndrome, after extubating, we can still give them some non-invasive ventilation or apply a CPAP. The CPAP pressure can be up to 10 centimeters of water. And then the average is the average or the range between 4 to 15 can be applied, or even higher. Thank you very much. Can we have the next slide? In the post-anesthesia care unit, PACU, we put the patient in 45-degree head up. We continue giving supplemental oxygen either via the nasal prong or via oxygen face masks, bare simple face masks or non-rebreather face masks can be used. If available, we can use a capnography in a patient that have obstructive sleep apnea. Using a CPAP, as we said earlier, if the patient is a known OSA patient, and then we minimize the use of opiates and embrace multimodal analgesia using non-opiate method like regional anesthesia, using our paracetamol, NSAID, and other adjuvants that can be used as anesthesia. Can you hear me, please? As I saw a complaint, as there is a noise. Is it okay now? No noise?
No, we
I
can
can
hear.
I can hear from my
Okay,
side.
thank you very much. Thank you very much. So
Maybe you check your end, because the professor is very clear. Yeah.
Okay, thank you very much. So this is what we do for the multimodal analgesia. Thank you very much. Can we have the next slide? As there can be some complication after the anesthesia, such as respiratory failure due to maybe atelectasis, if we don't have our recruitment maneuver or prevention of the atelectasis during the surgery. So there is a possibility of intubating the patients. When we have the basal atelectasis and pneumonia, we can now do some of our recruitment maneuver, give our oxygen, and then probably start the antibiotics and involve the pulmonologist. Sorry, thank you. Then for those with thromboembolic event, we can happen, but we can prevent it by using our pneumatic, intermittent pneumatic compressive devices and the use of low molecular weight heparin. Rhabdomyolysis and acute kidney injury can happen as a complication, but can be prevented by giving IV fluid and then keeping the kidney open and then minimizing the duration of surgery, and then maybe using pneumatic mattresses, and then avoiding compression that is a little bit much. Opioid-induced ventilatory impairment is also possible. If we have opioid-induced ventilatory impairment, we can reverse using the appropriate antidote like our naloxone, if available, or naltrexone, or at all, we can avoid using the opiates if possible. And then we can use our regional block, or we can use our local infiltration and other adjuvant of analgesia. Thank you very much. Next slide, please. So errors in obesity. So we have this a lot of studies about errors in obesity, which can be seen since we have a paper here as a review article. But we should understand that the carbohydrate loading in them is safe, because even if, as one of our teacher is saying, even if they are going to have a regurg, it's going to be a carbohydrate, not acidic. So it's safe. And then for the prophylaxis, we use triple antibiotic, triple therapy with using the antiemetics from different groups. They are for prophylaxis. For example, we can use an anti-dopaminergic, antihistamine, and also 5-H3 antagonists at the same time. Or we can also, where we check changes, maybe to use steroids. We use anticholinergic, and then the 5-H3 antagonists, like that. So this is a good one. And then the goal-directed therapy, as we said, we give our IV fluid, we follow the mean arterial blood pressure, we follow the urine output, so that these patients will have adequate fluid so that they are not going to be overdosed and overload. And then the fluid that we are going to be given, if we are using the goal-directed therapy, we are not going to base it on the body weight. And then the OSA precaution that we are going to use, maybe the use of CPAP or the use of PIP during the surgery, and then recruitment maneuver. And then for us to prevent, as I said, the venous thromboembolism, early mobilization is very important, and the use of low molecular weight heparin and the use of intermittent positive pressure compressive device. Early mobilization is very important. Thank you. Please, can we have the next slide? Bariatric surgery specific. When are you doing laparoscopic, this like this Roxanne Y or sleeve gastrectomy? The patient is in a position that you use the carbon dioxide to make a distended abdomen. And then they are using the reverse Trendelenburg plus this pneumoperitoneum. All will increase the pressure in the abdomen, and it will push the diaphragm and then reduce the volume of expansion of the lung, thereby decreasing the functional residual capacity. So all these high intra-abdominal pressure are very poorly tolerated in this group of patients. When we are going to do our rapid sequence induction, it has been found that the cricoid pressure, if you have the video laryngoscope, is not necessary. Sometimes it can even make it a bit difficult for you to intubate, but it is controversial. So we need to have our patient on the ramp position, you give our antiemetic, and then use our cricoid pressure, and then do, and then use our video laryngoscope and then intubate these patients. Thank you very much. Please, can we have next slide? Pool 4. A 38-year-old female with a BMI of 40 planned for sleeve gastrectomy, presented at Anaesthesia clinic for review. How will you plan your airway management? Ramping, video laryngoscope first line, PIP plus recruitment maneuver is to get patient awake and upright. All of the above. Please, can somebody help us?
Yes, Professor.
Yeah, okay, please go ahead.
I think the answer is all of the above. From the way you have taught, all of the things are valid to be considered.
Okay, thank you very much. Any other person with another view? Okay, thank you. So can we have the summary of the answers? Yeah, everybody 100%. So thank you very much. Can we go for the next slide? So the Society for Obesity and Bariatric Anesthesia of the United Kingdom guidelines, they are giving us that we should ramp all patients with a BMI of 35 and greater. And we should use video laryngoscope as our first line. And then this routine cricoid pressure in this position, the ramp position, is not necessary. I'm sorry. Recruitment maneuver, as I said, and the addition of positive end expiratory pressure is mandatory, and we need to extubate the patient awake and upright. The explanation was done before. Thank you very much. Please, next slide. The European Society of Anesthetists and Intensive Care 2022 guidelines highlight that perioperative CPAP in OSA is needed or is mandatory. So you can apply a CPAP of up to 10 centimeters of water. And then we need to give a perioperative high flow nasal oxygen. The typical starting is about 30 liters per minute, and then above up to 60 liters per minute. And we should use a long protective ventilation, as we said, using lower tidal volume, minimizing the inspiratory pressure. And then we should consider intraoperative long ultrasound for recruitment. So we can give that our sustained airway pressure between 30 to 40 centimeters of water up to 30 to 40 seconds, and follow it with our PEEP. Thank you very much. Can we go for the next slide? Okay, our take-home messages for this patient with obese patients is we should always anticipate difficulty in their airway management. So we should prepare early. We should remember that this patient are supposed to be in RAM position. Again, in RAM position. Again, in RAM position. We should have aggressive lung recruitment and PEEP. If whenever is possible and there is expertise, we should do opiate sparing, multimodal analgesia. And then we need to have a high risk OSA patient. We do post-operative CPAP, and this patient are to be managed in the high dependency unit or in ICU. And we should involve the respiratory physiotherapists early to start the chest physio for them. We should remember that early prophylaxis for to prevent venous thromboembolism is mandatory. So we can use our low molecular weight heparin plus intermittent positive compressive devices, and we should early mobilize the patient. So our pain management is very good so as to have early mobilization, because patients with pain-free can mobilize early. Thank you. Next slide, please. This is our reference. Thank you for listening.
Thank you very much, Dr. Mohammed, for this wonderful presentation. We are happy that the presentation was loud and clear for all of us, and the message was taken. There are a number of questions that have been dropped in the queue and question and answer. For now, as we are waiting for more questions to be dropped, I'll call upon the two panelists to make up a few comments and share their experience in handling obese patients during anesthesia. I can start with Dr. Ndaba, and then Dr. Sweetbeto will follow up.
Thank you very much. Am I audible, the moderator?
Yes, you are audible on my side. I believe for everyone as well.
Okay, no, thank you so much. I think first and foremost, I think that was an excellent presentation from the two presenters for putting up
We have lost you. We have lost you, SPK.
Hello? Yeah.
We have lost you.
You can hear me now?
Yes, now you are audible.
Okay, yeah. So thank you so much. Mine is an emphasis on I think preparation, pre-operative assessment, as well as preparation of these patients. I think when you do a good pre-operative assessment, you identify first of all, the risk factors that are associated with obesity, and you plan your anesthetic well. So everything, I think, starts with preparation. And I think one area of emphasis I would like to add, to the great presentation, when you prepare, is to anticipate, a difficult airway, and then you want to make sure that you have help at hand in order for you to be successful. I think when you take all the necessary measures, that from my own experience, you take all the necessary steps in preparation, you optimize your workspace, you have everything that is needed. I think you would win most of the times. My own experience, especially because we do a lot of spine surgery at my hospital, decompression, laminectomies. So we send these patients and operate in prone position. So that brings an additional challenge of airway risk, as well as the issue of managing the weight over pressure points. So that is also another area that's very, very important. And again, you need to make sure that you have enough help at hand, because you need to handle the physical aspect of the patient, the lifting, the turning. So it's really not an easy, operation. But once you anticipate, you prepare, you discuss with the surgeons, you put your heads together, I think you win most of the times than you would actually have any critical incidents. And with this knowledge that we've been given, it would honestly make things easier to handle this special population of patients. I'll end here for now. Back to you, moderator. Thank you.
Thank you very much, Dr. Ndaba. Dr. Sudbert, are you available? Can you also make some few comments? If you can also take one or two questions in the Q&A and then answer them live.
Okay, thank you. Thank you very much, Papicho, and also thank you very, very much. Thank you very much, presenters, for the nice presentation. I think on my side, I'll emphasize more also again on assessment and preparation. And when you see a obese patient, you should know most of the time you are dealing with someone with comorbidities. So thorough assessment, including investigation, assessing any organ involvement from any comorbidity is also important. But also the most important thing is always remember different airway is always around the corner. And I know most of our centers, we don't have those facilities like video. We don't have much luxuries. But simple thing like positioning, they will always save your life. So don't take you for granted when it comes to obese patient. At least make sure you position the patient proper the way it should be, or the way it is. For your assessment, you are the final judge. You are the final judge depending on the assessment. But lumping will always help you in most of the time. Yeah. So there are some questions. Completion with Thromboembolism, yes. I think also here it depends on the surgery and duration of the surgeries. And I know, as we said, prevention of embolism should not rely on one thing. But I remember Dr. Mustafa emphasized on ablation. So your assessment, because you have to do assessment and see if there's a risk for thromboembolism and prior for the surgery. If there is, you have to take some measures. If not, of course, stalking might not prevent that much unless the surgery is prolonged. But other things like intermittent compression, early ambulation can always, of course, also using drugs like heparin and all those can always save you. Another question was during morbid obese obstetric, what recommend GA, spinal. I'll say we all recommend, especially spinal anesthesia is safe for obstetric patients. It always will be safe for obese patients, especially in the communities. But also assess for patients if there's no any contraindication for general anesthesia. We all understand any of them can be used, but for someone who don't have contraindication with the regional anesthesia, I'll go for regional anesthesia straight. Another one. Another question is which.
A quick one, Dr. Sweetbert. In the chat, they're also asking if one can make a comment on the errors. Can you just briefly comment on the errors?
Okay. So, thank you, Ndam. So basically, errors is kind of getting sick now. I would say it's no longer a new thing, but it's kind of new in some of the hospitals. So errors is the initial recovery after surgery. So which means we are aiming on making sure the patient is moving as early as possible. Of course, with advantage we know, like you have said, preventing embolism, preventing pneumonia. It has so many advantages all the way to costly and to cost to the reducing cost to the patient, reducing length of stay, and also it has also an advantage on the facility, which comes with the high turnover of the patient. So you try to use technique which will save time and for patient, of course, making sure that you everything is done well. For example, make sure you manage your pain well. There comes maybe regional anesthesia, multimodal anesthesia. You make sure you manage nausea and vomiting. Make sure you prevent from any kind of sickness post-op. Procedure itself, so if they're possible for minimum invasive, is allowed. And the LS actually basically starts starting during the clinic, whereby you have to explain everything to the patient, to the relative, those whatever. I'm sure you're all doing the anesthesia clinic, so that's where you start the journey, whereby everyone who is involved with care of the patient has to understand it. All the way to day of admission, all nurses, they should know what should be done. For example, now we have seen some people, they do give carbohydrates loading. Some people, they give fluid all the way for surgery. So everything has to be planned well to make sure you prevent even dehydration, make sure someone will be operated and won't get any kind of sickness post-op. Some centers, they even involve physiotherapists, whereby they're involved with the patient so that they can move earlier. So it's a kind of it's multidisciplinary approach to the patient, aiming to make sure the patient moves as early as quickly as possible. Maybe we can have the email for whoever asked the questions, or we can send some articles. And basically, it started with colorectal surgeries, but now it has gone through all the way to C-sections. So It's almost in every surgery now. There's a protocol for how to can apply errors on procedure specific. I think I will end there, then we can discuss more later on if time allows. I'll give opportunity to another.
Thank you very much. One more question is that it's specifically addressed to Dr. Amida in the Q&A, where they ask if you can talk more about the pre-oxygenation that you mentioned, and the other one on the recruitment maneuver. Just a summary. Dr. Amida, are you still there?
Okay, maybe I she can come late. So discussing recruit maneuver, there are machines which you can of course you can do it manually, whereby you can set it, you can increase speed, and of course certain time period. Make sure you recruit. You make sure there is no atelectasis. But also you can play it with the pressure. There, one point to rise up your pressure a little bit higher above what you are meditating is. Because remember, we advise with the low tidal volumes, making sure to prevent bladder trauma and volume traumas. But of course, using PEEP and also using pressure, we can prevent you from the collapse of some alveolar. And there are some machines, they come with the what's so-called sign properties, whereby once you set sign on, the machine after a certain cycle, it lies up pressure to put some alveolar. So also that you can help you. So if you have your machine, you can go and check. If it has sign, you can always put the sign positive, which means after a certain cycle of the ventilation, the machine will realize the pressure on its own, make sure it recruits some alveolar. What would another one? Maybe she can go there and the second one.
Okay, thank you. As we are looking for one, Dr. Sweetbird, I can also quickly pick this one on dose of bupivacaine. It has come twice during pregnancy. The question has been repeated twice. I would just say to our colleagues that bupivacaine dosing in pregnant, one have to be very cautious on the dose that you are giving for the reason that we know space has reduced because of the engorged vents. So usually very low doses are often effective for our pregnant women. So for hyperbaric 0.5%, a dose of like 8 to 10 milligrams is usually effective, and especially if you add up some fentanyl to even give you a better analgesia and make you reduce even further the volume to minimize complication. You don't look at the size of the patient, then you go high, otherwise you end up giving more volume than what it should be given. And when it comes to the last question that was asked by one of our participants, how can we prevent atelectasis? Just like it was said about recruitment maneuver, you do recruitment carefully without going from low PEEP to high PEEP. You go slightly checking how your tidal volume is increasing, how your saturation is increasing. If you have a more improved machine, it will even help you when you press recruitment maneuver, and then it will recruit progressively for you. So let's not rush to push in figures that can end up causing trauma to the patient. Yes, Dr. Sweetbird, if you have one more question, you can pick it up as we are looking at closing now. Are you still there? I think we've lost Dr. Sweetbird. Meanwhile, I'll call upon Magdalena to give final remarks. Maybe we can also make a comment on the certificate. There's a question being asked if certificate will be given for the attendance of this presentation.
Okay. Thank you all for everything, for joining us. Thank you for Professor Abdullahi and also for Dr. Chande. Thank you for the presentation. Thank you for the attendees. We really do appreciate. For the certificates, we always recommend that you probably attend consecutively, and then that we will, once we note that, then we can look forward to offering a certificate for that. We thank you so much for your attendance. In case of anything, please reach out to us. Mariam had shared the last page, she had shared our contacts. Don't hesitate to reach out to us. The webinar will also be shared. Also look out for more webinars, and look out for our communication also on our platform, our online on our website. We also do, for those people who have our machines, we have our WhatsApp groups. We always communicate whenever we have webinars. Don't hesitate to call us in case you have our machines and you need us to reach out, service, more training. We will always look out for ways to support you. And for those of us who would like to know more about our machines, please reach out to us. We'll always be there to support you. Thank you so much, and please look out for more webinars, and it's a pleasure having you. Bye.
Thank you very much. See you next. Bye. For more answers to other questions, we'll answer them in the emails.
Thank you very much. Thank you very much.
Thank you, everyone.
Thank you, everyone.